Okay. Bismillahirrahmanirrahim. This session is recorded. I'm Dr. Muhammad Talat, Assistant Professor of Pediatric University. This is the second MSK VIVA session. To share or interact with us, you will find the link of our WhatsApp group interactive teaching session in the first comment, inshallah. Okay, let's go by the first candidate. Patient is presenting with shoulder instability.
Okay, sir, I have an X-ray frontal view of a mature skeleton patient left shoulder.
Okay.
Okay, although the glenohumeral joint looks intact at this view, but the inferior aspect of the glenoid shows some bony fragments suggesting and cortical irregularity suggesting fracture, a bony Bankart.
Okay.
And according to the history you provided, sir, there is instability. I think out Bankart lesion, and this
Okay.
is Osseous Bankart. Also,
Okay.
when I look carefully to the humeral head, I can see there is a depression at the superior lateral aspect.
Okay.
Altogether, the fracture in the glenoid inferior aspect and the depression in the superior aspect of the humerus. This is a Hill-Sachs lesion associated with Bankart lesion.
Okay. So yeah, very nice.
Thank you.
Okay. Can we localize the fracture that you picked up? I think this one. This part.
Yes, sir. Yes, sir.
Okay, that's good. Okay, and I think this is the defect of the bone. This area. It is considered as a subtle abnormality, but it's present. And considering the history of the patient, you should search for any bony fragments along the inferior glenoid articular surface. Okay, I think you have here some sclerotic margin, maybe impacted cortical defect at this area. May represent Hill-Sachs or not. I'm not sure. Let's go. What will we do for this patient to confirm your diagnosis?
This patient will need the CT for confirmation of osseous changes I suspected in the X-ray, and also MRI to assess the glenoid labrum itself and other soft tissues like tendons.
Okay. Okay. Let's go to the MRI. Okay. Which sequence you want to select and you want to watch?
For the osseous changes, maybe T1 coronal maybe good.
T1 coronal. Okay.
Yes. Okay,
I'm sorry, the image is slightly bit hazy.
The motion artifactness.
Yeah.
I think also the bony fragment is seen and it's separated from the glenoid, and the inferior aspect of the glenoid is a confirmation of our finding in the X-ray.
Okay.
And also if I can see the Hill-Sachs also here in this bony depression maybe there or.
Okay. Let's go first by the axial T2 with image. Okay, let us see axial T2 gradient. Can you see any abnormality?
Of course, yes, sir. At the anteroinferior aspect of the glenoid, there is a bony separation at the base of the anteroinferior labrum.
Yeah.
Yes, sir. Yes, sir. And this confirmed the Osseous Bankart we said before, and also the surrounding marrow edema subtle also. Suggesting this is not acute injury. And if we scroll up to the level of coracoid bone, I can search for the Hill-Sachs or any other. Yes, here, maybe down. Yes, here. Also, there is a flattening and irregularity of the bone. May suggest Hill-Sachs, but maybe it's not very clear.
You mean this area?
Yes, sir.
This area is away from the Hill-Sachs side. This one is much posterior. Just we need to focus on the posterior aspect or posterolateral aspect to search for any Hill-Sachs injury. I think we can demonstrate this one in this image. But yeah, I agree with you that we have here a fracture line across the anterior inferior aspect of the glenoid and separated bony fragment. This is osseous fragment, Osseous Bankart fragment. And we have here, this is the labrum, and this is the periosteum. I think it's intact attachment to the osseous fragment, to the separated osseous fragment. So for sure we have here Osseous Bankart. I think axial T1 also can demonstrate the fracture very clearly.
Yes, sir.
And you can see here, this is the site of the fracture. Okay, let's go to the coronal stair. Yeah, look for this marrow edema pattern here. This one here indicates that we have Hill-Sachs injury along the posterior superior aspect of the humeral head. Yeah, so we have here for sure, we have a case of Osseous Bankart lesion. Okay, that's good. Just I would like to review a small tips for the shoulder dislocation.
ممكن سؤال بس في الاكس راي؟
اتفضلي.
هو هل كان في داونورد ديسبيسمنت للهيومرال هيد؟
That's why this is an important point I would like to emphasize. Just a minute. I will share for you again the X-ray. Just a minute. Can you see again the X-ray?
Yes, sir.
Okay. I think, yeah, you are talking about this downward sloping. This one, it's false projection from the X-ray, from the tube. So it gives you false impressions that the humeral head is dislocated anteriorly, but really, clinically, the patient is reduced. The shoulder dislocation is totally reduced at its normal location, and also this interaction or this look for this one. This is moon-like interface. That means that the humeral head is in normal relation to the glenoid articular surface. If we have anterior shoulder dislocation, it will be located under the coracoid process, subcoracoid. If it will go more, it can be under the clavicle, subclavicular, even can be intrathoracic. Okay, so at this point we don't have an evidence. We don't have any evidence.
Downward displacement مش قصدي
downward
anterior.
Downward displacement, the projection is misleading. It's not accurate. Yeah. We did MRI for this patient at the same setting. Okay, so we don't have any anterior dislocation in the MRI. So this is false impression. Okay. Okay. Let's review together some tips regarding the anterior shoulder dislocation. We have here many types that explain anterior shoulder dislocation. If we have Bankart lesion, Bankart means that we have an interruption of the labrum and the periosteum at the same place. Osseous Bankart, the interruption at the level of the osseous attachment. Reverse Bankart, this one for posterior shoulder dislocation, versus this one interruption of the labrum, but with intact periosteum. Let us make this one. This is intact periosteum, and Alapsa also intact periosteum, and the glad with intact periosteum. Those three types with intact periosteum. Here is the labrum is disrupted in bursus. Here in Alapsa, the labrum is disrupted and displaced medially. Glad here the glenoid articular surface itself is disrupted. Okay, so those are the most common types of anterior shoulder dislocation. Okay, let's move to our next case. Can you see?
Yeah. Yes, Dr.
Yeah. Okay.
This is a frontal radiograph of the pelvis. Is there any history for this patient? Trauma history?
No trauma.
Okay.
No trauma.
Okay. I can't appreciate any acute bone injury, but I can see that there is some sclerosis in the right femoral head.
Okay. Very good.
And actually, it is heterogeneous in pattern.
Yes.
Like there is small areas of small lucent areas as well.
Yeah.
And yeah, I can't appreciate any other abnormality there. So yes, I think there is heterogeneous pattern of for the right femoral head with small lucent areas. Is there any swelling in soft tissue surrounding it? I think there is. Maybe.
What do you think?
Yeah, I think there is a soft tissue swelling there surrounding the neck and the femoral head as well. So yeah, what is the history of the patient?
Hip pain.
Hip pain. Okay. Okay, so I'm suspecting that this might be an early change of avascular necrosis. I would like to notify alert the referral physician and ask for MRI hip, right hip for confirmation.
Okay, that's good. Okay, so as you said, we have here frontal radiograph examination for the pelvis and post hip joints. And as you said, we have at I think at both sides, it's not only on the right side.
Yeah, it's more evident on the right side.
More evident on the right side, yeah. Okay, so we have a geographic patch area of sclerosis at both sides. Is that correct?
Yes.
Also, we have some lucences inside this sclerotic area. And also, I think we have like sclerotic margin here, serpiginous line. Do you agree with me?
Yeah.
Okay, and I think the femoral head itself doesn't maintain the smooth rounded contour of the head. Do you agree with me? We have for a little bit subtle flattening, subtle irregularity. Do you agree with me? Okay, so you can suspect that we have bilateral femoral head avascular necrosis. And which grade is one? Do you know?
No, not really.
Okay.
That's great.
Is this one a bony disease or articular or joint disease? Is this abnormality is considered as a bony? Bony, because the acetabular articular surface is very smooth, and we don't have any changes on the opposite side. So we are dealing with pure osseous lesion, bilateral femoral head avascular necrosis. We have different grades for avascular necrosis. First grade, minor osteopenia. Second grade, geographic areas of mixed sclerosis and lucency. The third grade, like the second grade, but we add subchondral fissure, and also if we have some flattening or irregularity of the femoral head, I think we are going now between grade 2 and grade 3, and more likely toward grade 3. Grade 4, if we have secondary osteoarthritic changes. So we don't have secondary osteoarthritic changes. Do you agree with me?
Yeah.
Yeah. Okay. So in any case of femoral head avascular necrosis, you should comment on the complications. You got the abnormality, but you didn't mention the complications. We don't have secondary osteoarthritic changes, so you should enumerate the complications. Okay. Also, we should search for the cause. Do you have any evidence of the cause? How can we search for the causes of avascular necrosis of the femoral head?
We should look for the vertebrae. If we saw H-shaped vertebrae, we suspect sickle cell, splenomegaly. What else? If the patient, we need to check the clinical history if the patient is on steroids.
Okay, you are right. Okay, let's take or conclude. What did you say now? If we have like this is the abdomen of the patient. Okay. On the right side, you should check the gallbladder. Is there any gallbladder stones, polycystic collapse, or something like this in young age? So you should suspect sickle cell anemia. If we have splenomegaly at the left side, splenomegaly can explain Gaucher disease, sickle cell anemia, also myelofibrosis. Sometimes the spleen, autosplenectomy or splenic calcifications can suggest also sickle cell anemia. If we have pancreatic calcifications, this one can be secondary for chronic alcohol drinker or drinking alcohol for a long period. So this one can make chronic pancreatitis and at the same time avascular necrosis of the femoral head. Also, the H-shaped vertebrae is pathognomonic for sickle cell anemia. Also, the post-sacroiliac joint. It's very important to comment on the post-sacroiliac joint here. If you find any sacroiliitis, this one can make any suspicious for ankylosing spondylitis or something like idiopathic sacroiliitis that can explain that the patient received long-term corticosteroids or endogenous corticosteroids. Also, if we have ileostomy bag, this one can raise the possibility of inflammatory bowel disease. If you have surgical collapse in the pelvis, for example, here or here, so you have history of renal transplant, and renal transplant patient can receive long duration of corticosteroids in combination with the immunosuppressant drugs. So all of these clues can help you to determine the causes of the avascular necrosis. If you find avascular necrosis in young adults or in pediatric patient with Erlenmeyer flask-shaped femoral shaft, you can think for Gaucher disease. Okay? Thank you so much. Let's go to the MRI. Is it confirmed now?
Yes, sir. This is MRI coronal T1 sequence. I can see that both femoral heads appear irregular contour with low signal intensity.
Correct.
And I would like to check also in the STIR sequence.
Okay. Let's just take coronal STIR. Okay. Can we zoom that? Okay.
In the STIRs, there's
I think, as you said, we have a necrotic area at this area, and we have marrow edema pattern, and we have also here. This is a very good sign. Do you know the same of the sign? Here we have double line sign. Okay. Yeah. Okay. Agree. Double line sign, outer dark area of sclerosis, and inner bright area of granulation tissue. This one is a trial of the bone to revascularization. So we have double line sign, pathognomonic for avascular necrosis of the femoral head. Also, we have bilateral moderate joint effusion.
Yeah.
Okay, that's good. Thank you so much.
Thank you, doctor.
Also, I would like to add one of the differential diagnosis for the avascular course of the femoral head. This case of diffuse marrow edema pattern along the femoral head, neck, and intertrochanteric region. And this edema pattern is very extensive than the case that we saw before. And also, we don't have any serraceous lines. We don't have any double lines. We don't have any lines that can explain a case of avasculosis. So this case is idiopathic transient osteoporosis of the hip joint. This one is very important because sometimes the classic treatment for this case is corticosteroid therapy. So please be sure that you can differentiate between avasculosis and transient osteoporosis of the hip, because avasculosis of the femoral head, the cause can be corticosteroid, while in case of idiopathic transient osteoporosis of the hip, as you see here in this case, corticosteroid can be the treatment, can be one of the tools to treat this case. So this point is so important in your reporting.
This is a radiograph or a frontal radiograph of the right ankle for
Yes.
a child.
Yes.
Okay. I can't see. I can see there's lucent line there in the epiphysis of the tibia, the distal tibia.
Yeah.
And I think it's going through the physis as well.
Okay.
There's some sort of soft tissue swelling at the ankle, at the level of the ankle joint.
Okay.
Yeah. Okay. No bone lesion, no other acute bone injury. So I think this is a fracture.
A fracture. Where is a fracture?
There's a fracture there in the physis of the distal tibia. This should be Salter-Harris type. It takes a Salter-Harris type 1.
Okay. We don't have any trauma.
There's no trauma. Okay.
Yes. We have pain and swelling.
There's soft tissue swelling.
Yes.
Can I see the lateral again? Sorry.
Okay.
Yeah. Okay. But I can see there is abnormality there in the distal tibia. But I think there's a lucent area there as well at the lateral side of the tibia.
Okay. Let's conclude this case. We have AB, or frontal radiographic examination for skeletal immature patient, and we have, as you said here, we have something abnormal here along the lateral aspect of the distal tibia. Do you agree with me?
Yes.
Okay. Really, let's go to our second. What do you think? How can we justify or characterize this lesion?
If we are suspecting
that this one it's not specific for something.
I would like to do maybe CT, but because it's an old, young patient, I will do MRI to avoid the radiation.
Okay. We did MRI for the patient after 3 weeks from the X-ray.
Okay, this is an axial stair cut for of the ankle. I can see that there's a soft tissue edema and bone high signal of the bone marrow as well in the distal tibia.
Yes.
Can I see another plane? Yes. Okay, and
I agree with you that we have diffuse marrow edema involving the distal tibial shaft, metaphysis, and also epiphysis, and we have also
this focal area of intense high signal seen in the distal in the epiphysis of the distal tibia.
Yeah. And also the periarticular musculatures and soft tissues.
Periarticular soft tissue edema and
as well. Okay.
inflammatory changes. Yeah.
Yes. Okay.
Is this a fracture line seen in the talus as well?
The fracture line along the talus.
This line in the talus? No.
Where is this line?
Okay, this is no, it's not a fracture line. Okay.
We have here an osseous lesion. Do you agree with me?
Yes.
Okay. Where it is located?
It's located in the distal metaphysis of the tibium.
Yeah, okay.
And including the epiphysis as well.
Okay. So we have this lesion is metaphyseal in its center, and it's crossing the physis and reaching the epiphysis. Do you agree with me? And also we have here an evidence of cortical breaching.
Cortical breaching.
Yeah. The lesion displays low signal intensity and with peripheral faint rim of high signal. This is called penumbra. Penumbra, sorry. Penumbra sign. Penumbra sign, the high signal intensity in T1 surrounding the lesion. Is it pathognomonic for something?
Osteomyelitis.
Or is it suggestive? Yes. Osteomyelitis, yes. Or something like here, like Broadies abscess. Okay. Really, when I saw this case, I suggested Broadies abscess at this area. And I think we did sagittal T1 with image. I think coronal will be much better for you. It's briefly enhancing. And even the soft tissues are also enhancing. We have also reactive changes, significant edema changes, very articular and very osseous. And this one is helpful to determine that we are dealing with an osteomyelitis or infection. Okay, so let's review also the X-ray at that time. Okay. Yeah. Can you describe for me, please, this lytic lesion? This is a patient we did for him X-ray, I think 2 months after the initial X-ray. Can you describe with me this case?
This is a frontal radiograph of the leg. Shows a lucent lesion, eccentric lucent lesion with thin sclerotic margin, narrow zone of transition seen in the distal metaphysis of the tibia with cortical breaching. And I think there's some no aggressive periosteal reaction.
I think we have
there's just a solid
fine
cortical thickening.
Okay, and also I think the lesion is extending into the epiphysis. I think you agree with me that we have significant progression of the lesion as compared to the initial X-ray. Okay, that's good. So really I diagnosed this case as a Broadies abscess, and after 2 months I will show you what happened for this case. What do you think after 2 months? Is there any progression or regression or improvement?
No, it's progressed.
Progressed, yeah. I agree with you. The lesion is much progressed. Okay. Let us see. I want to look for the lesion now. It's very progressed. Also, I would like to show you the sagittal. Look for the lesion. I think we have here an extraosseous soft tissue.
An extraosseous.
Yes. And also, it's very clear to have extension across the physis into the epiphysis of the lesion of the tibia. Can you add something here? Is there any more data that you can see in this image?
I think extra data. Just the soft tissue there, and
if we have any
in the talus as well, there's a. Is there any lesion there?
No.
No. Okay.
No. If you have any infection or osteomyelitis near the joint, is it what will you search?
For septic fluid, septic arthritis.
Yeah, that's correct. So you should search for any signs of arthritic changes. Search for the synovium itself. Do you agree that we have synovial thickening? Do you agree? This is the synovium. Yeah. It is thickened, enhancing. So we have something like synovial arthritis, septic arthritis, early septic arthritis in the ankle joint. And I think also here, the synovium here is much thickened and enhancing. So really, when I saw this case, it's a progressed case. And in spite of medical treatment, the lesion is progressed. And but at the same time, I have metaphyseal lesion with epiphyseal extension tunneling into the epiphysis, one of the most characteristic sites or most characteristic signs for Broadies abscess. Also, we have penumbra sign, high T1 signal along the margin. Also, we have complication for early septic arthritis of the ankle joint. All of these criteria are matching with Broadies abscess and osteomyelitis. Really, I don't know why this patient was not improved by the medical treatment, but they decided to take aspiration from the ankle joint. And I think after this aspiration culture and culture sensitivity was done, and the bacteria was treated very well later on. And I would like to show you the end result of this case. This is an X-ray for the same patient after 1 year. As you can see here, the epiphysis returned to its normal height, normal configurations, and also the net lesions shows an evidence of sclerotic reaction. So we have here healing process. Also, the cortex returns to its normal continuity. So we have here healing process. Just I would like to mention that this lesion, the first possibility is Broadies abscess. The other remote possibilities may be histiocytosis, maybe metastatic lesions. Sarcomas, it's for a little bit far away, but I think is the most logic thinking, the most logic diagnosis here in this case is Broadies abscess and osteomyelitis. Okay. Yeah. Thank you so much.
Thank you.
Just I would like to add something very important in this case of Broadies abscess. If you want to review the metaphyseal lesion, we have central causes of metaphyseal lesion and central causes of the metaphyseal lesion. The central causes is enchondroma and simple bone cyst. Along the eccentric lesions, osteochondroma and aneurysmal bone cyst and osteosarcoma. Those are the eccentric lesions at the metaphysis. If we have an epiphyseal lesion, chondroblastoma is very important. This one before age of 20. Clear cell chondrosarcoma after age of 20 can occur in young adult patient. Giant cell tumor in the age between 20 and 40. This one is locally aggressive tumor, subarticular location. Jude or intraosseous ganglion cyst also can be within our epiphyseal dendritic lesions or cystic lesions. Also, we can add plasmacytoma, one of our differential diagnosis in the epiphyseal lesion, but it's very, very rare. Plasmacytoma. I would like also for metaphyseal lesion, we can add Broadies abscess. Broadies abscess can occur metaphyseal with epiphyseal extension.
في history يا دكتور بعد اذن حضرتك؟
back pain, upper dorsal back pain.
upper dorsal back pain. في upper dorsal vertebrae heterogeneous يعني appearance كده وفي some sort of thickening او widening في posterior neural element of the related posterior neural element.
Okay.
So I think so ان في fracture برضه في right posterior neural element. ايوه this level في fracture line.
طب let's see the surgical plane.
Okay. او corona. نفس الفكره فيه heterogeneous predominantly sclerotic upper two vertebrae. مش عارفه احدد الدورسال يعني غالبا هيبقوا
this is the third.
Okay, third.
If you count the reps, you will find this one is the third vertebral body. And I agree with you that the third vertebral body here appears heterogeneous sclerotic.
I think so برضه اللي فوقيه بس مش متاكده برضه. بس هو البريدومينانت هو الثالث وفي برضه
this vertebral I think this one is
الاليمنت بتاعها برضه نفس الابيرنس وفيها
very nice. Okay, you have here permeative lytic lesion, heterogeneous lytic lesion extending from the body and the pedicle and the lamina and spinous process.
Yes.
At the right side. Also, I think we have here, as you said, this is the area. This is a permeative lytic lesion.
Yes.
Okay. And we have also an extra osseous soft tissue component
انا
paravertebral.
كنت هطلب من حضرتك ان احنا فعلا نعمل السوفت تيشو ويندو لو في
Yeah, I will give you the soft tissue window. Just a minute. Okay. I think also there is a suspicious intraspinal.
Yes, intra-thoracic برضه intraspinal soft tissue component.
Yes. So we have
على related dorsal spinal
right neural exit. Okay. And also we have a suspicious of intraspinal soft tissue component compressing the spinal cord. Okay.
Yes.
What is your diagnosis or differential diagnosis? What is the next step?
طب هل في اي هيستوري للبرايمري مع العيان؟
No.
No. طيب فيفر اي constitutional symptom؟
No.
No. الصراحه شكلها اجريسيف. انا افكر في نيوبلاستيك بروسيس سواء كان برايمري او سكندري بس موستلي سكندري.
Agree. Yes. So we are dealing with an aggressive features, aggressive lytic lesion, permittive lytic lesion of T3 vertebral body.
Yes.
With extra soft tissue component, and I think what's your diagnosis? What do you think?
يعني صراحه تفكيري رايح اكتر ان هي تبقى ميتاستاتيك لان الميتاستاتيك هي بتافكت البوستيريور نيورال ايلمنت اكتر من البرايمري مالجنسي يعني.
Very good. I think the lytic lesion is centered upon the pedicle, right pedicle, and extending to the vertebral body and spinal process. So the most logic thinking is that we have metastatic lesion. The other differential diagnosis may be myeloma, maybe lymphoma, maybe other infiltrative lesions, osseous lesion, primary osseous lesion. But I think this is the most logic thinking. So we did for the patient metastatic workup. This is a CT scan for the same patient.
يعني انا مع حضرتك يا دكتور. تمام.
Okay.
هو في ريكتو سيجمويد كده ميورال ثيكنينج irregular mural thickening.
Very nice. Yes, you are right.
يعني رابط circumferential بس irregular mural thickening عامله انكروشمنت على الوول وناروينج قصدي انكروشمنت على اليومن وناروينج.
Yes.
with some sort of soldering في البوث ends يعني فده لا وفي some sort of smudging للsurrounding fat balloon with nodularity.
Okay. And also I think we have paracolic lymph nodes.
Yes.
Maybe metastatic. Yes. So this is a primary.
could be a primary.
Yes. And also we have.
هل ممكن نقلب البون ويندو برضه يا دكتور تحت ممكن نلاقي برضه.
Yeah, right. Okay. So really, I don't have really the bone window. I'm sorry.
Okay.
Okay. But we need
if we take the window طيب بالماوس ولا لا؟
Yeah. Okay.
Yes.
I think.
يس كليروتيك بون يجي موجوده في الرايت سكرم في الرايت إليا في الرايت يس بس موستلي شكلها مش مالجنت يعني.
Mostly not malignant and non-aggressive. Okay, I agree with you. So we have the primary tumor is colonic carcinoma, colonic adenocarcinoma with metastatic osseous lesion and the DC. Okay, that's good. Thank you so much. Let's.
Okay, sir. I have here an MRI sequence images for both thighs and knees. I think this is T2 sequence. The hallmark of the findings is of course this is immature skeleton. This is maybe a child or something, and the hallmark is the abnormal marrow signal of both femori and both tibial bones.
Okay.
There is heterogeneity of bone marrows, and there is multiple focal lesions infiltrating the marrow.
Okay.
Also, around both mid shafts, there is some fluid collections.
Very good. Along the medial aspect of the both femoral shafts.
Yes.
Okay. Let's move to next plane.
This is the T1. Okay. The marrow signal is abnormal still, and it's hypo-intense than the normal appearance of the fatty marrow.
Okay.
And I am also surprising that what I think is the fluid collection at the medial aspect of both femori now is they are displaying high signal in T1.
Very good.
This is not pure fluid, maybe containing blood or fat or.
Yes, agree. Totally agree.
Okay.
What is the age of this blood? Is it acute, subacute, chronic?
I think it's late subacute or something.
Okay. Methemoglobin. Okay. High signal in T1 and T2.
Okay, yes.
Okay.
Okay. I can give some possibilities for this patient. If we have multiple marrow lesions in all the examined bones, and we have also subperiosteal collections of subperiosteal hematoma.
Very good. Very nice. Yes.
And these lesions are serpiginous, and some of them are subcortical, like in the right distal femur medial condyle. Maybe all of these are bone infarcts or something.
Very good. So I think we have multiple osseous lesions. For example, this area, serpiginous outline.
Yes.
Also, we have multiple. I think you will find here multiple serpiginous osseous lesions. You will find the lesions are surrounded by serpiginous outline.
Yes.
So, as you said, you are suspecting some sort of osteonecrosis, extensive osteonecrosis.
Yes.
In post-femoral shafts and scanned upper tibial shafts, and at the same time we have subperiosteal hemorrhagic collection.
Yes.
Okay.
Okay, I can give. According to
what's your opinion?
I can suggest, according to the findings and the age group of this patient.
Yes.
Of course, we are in front of infiltrative or bone marrow process, abnormal process, and the multiple infarcts and hemorrhagic component of the superior circulation, suggesting we are maybe in a sickler patient.
Very nice, very good. Okay, so you got the diagnosis. We have a sickle cell disease, sickle cell anemia with multiple extensive osteonecrosis of the femoral shaft and post-tibial, and we have also subperiosteal hemorrhagic collection, more sizable on the right side, subperiosteal hemorrhage or hematomas, and this is considered one of the complications of the sickle cell anemia. Also, the other differential diagnosis is subperiosteal abscess. Do you think that this one can be subperiosteal abscess?
Okay, if we are afraid of an abscess, it will have the similar signs as you said in the previous case of osteomyelitis. It would also have
penumbra sign. We don't have any penumbra sign, and also the collection itself. All the collections display high signal intensity in T1
not
with
only the periphery.
Yes. Okay, and also I think if we try to see the diffusion with images, I think there is some distortion of the image as this area because of that can distort with images.
Yes.
Also, if you find something like high signal in the diffusion, you should correlate with the EDC map. What do you think is the EDC map?
No restriction. No true restriction.
No restriction. High signal as EDC map. So the other differential diagnosis is subperiosteal abscess or salmonella infection, but I think this one is going to be subperiosteal hemorrhage, not abscess, one of the complications for the osteonecrosis. Also, we did for the same patient MRI hip joint, and we have here
events.
Yeah, avascular of the femoral heads. Also, we have abnormal marrow signal of the iliac bones and pelvic bones.
Yes.
We have also, I think the coronal stair will be much helpful for you.
Yes, it's obvious normal marrow signal being bright rather than dark in stair.
Yes, you are right. We have multiple areas of osteonecrosis, and by the way, the low signal intensity or intervening low signal intensity of the marrow, this one representing red marrow conversion or bone marrow conversion. It's very common in this condition. I think we have also bilateral joint diffusion, hip joint diffusion. So this is a case of sickle cell anemia complicated with subperiosteal hemorrhage. Thank you so much.
Thank you, Doctor.
Thank you for your attendance. And
دكتور عايز اسال سؤال قبل ما حضرتك قبل ما حضرتك تقفل.
يس اتفضل.
معلش انا بس ما ركزتش في البنمبر ساين عشان نفرق بينها وبين بين الهيمة.
اوكي.
حضرتك تقول لي الفرق بينهم ازاي؟
حاضر. ممكن نشوف الكيس اللي هي
انا لحقتها كلها عشان في الشغل.
مفيش مشكله. حاضر ممكن نجيبها لكم اللي هي 1 جول 20.
معلش انا هراجع حضرتك.
لا خالص مفيش مشكله. لا خالص. لا مفيش مشكله. احنا ممكن نوريكم الكورونال T1 again because some candidates want to see the penumbra sign. This is a coronal T1 with image, and as you can see here, this area is dark signal.
Yes.
And this area relatively bright signal. Okay. So the bright signal, this bright signal is surrounding the low signal intensity of the lesion. The margin of the lesion, if it is displaying high signal intensity in T1 with image, this is called penumbra sign, and you can see it in many cases of abscess formation at anywhere. If you are suspecting abscess formation at any site, anywhere, please concentrate on the T1 and search for penumbra sign. Okay. Is that enough? Is that okay?
Yes, okay, Doctor.
Thank you so much. Okay, I would like to thank all of our audience, and I would like to emphasize that we have a YouTube channel, Easy Radiology Approach, and we will write the WhatsApp link for our interactive teaching cases in the WhatsApp. You can join us and you can interact with us. And inshallah, we are happy to see you joining us in our group and in our interaction, inshallah. And thank you so much.
جزاكم الله خير يا دكتور. ربنا يبارك في حضرتك يا رب.